Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Welcome to FHEA's Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Hello and welcome to another episode of Scrubs and Subpoenas. I'm your host, Jonna Emil, and joining me, of course, again is Dr. Sally Miller. Dr. Miller, how are you?
I'm well, thank you. And you?
Very good, very good. Happy to be here with you again, telling these wonderful stories at the beginning of the week.
Right, Monday. Here we are, Monday again. It just comes so fast.
That's
the
right.
Weekends are so short.
They really are. They really are. But no, honestly, really, we really do love having these conversations and sharing this with all of our listeners. Every time we have a conversation, I learn something new. I freak myself out in a new way also, which is kind of entertaining, but in a good way, that it really makes me thoughtful about things that I probably just wasn't considering as a nurse and as a patient. So I appreciate these stories. And I have two pieces of paper today. Normally, I have one when I have to make notes about the things that you're saying. And I'm like, I have to look that up later. But I've learned that after a couple of these episodes, I need two pieces of paper to look up some of the things that we're talking about. So I'm really excited to hear today's story. And with that said, Dr. Miller, I'm going to turn it over to you. And when you're ready to rock and roll and give us that first little bit of information, we're ready to be detectives and follow along with you.
I'm ready when you are. Well, we've talked about this before. I've kind of given up trying to be like really neutral face, neutral narrative and have you guess. Maybe you will and maybe you won't. But as always, I'm just the facts, ma'am. Just the facts, just like that old show. Was it Dragnet? Does anyone even know what I'm talking about? Probably not. Anyway, just the facts, ma'am, are these. So this is a story. This is about a patient who was for quite a while lived in assisted living, and then she went to become a long-term resident in a rehabilitation facility. And the NP, who is the subject of the conversation, was an NP who makes home visits in those facilities. So this patient, as I read through the chart and read about her, she looked like a really happy lady, and it looked like she was really happy with her life there in the facility, which is always nice to hear because you hear stories and there's such a negative connotation sometimes. But this lady, it looks like she initially went to the facility it was like several years ago. She was there for a couple of years. She had the usual suspects in terms of chronicities when you get to be, I think she was 79 when she first went to live there. She had a number of chronic medical conditions, but they were well managed. She had some neurocognitive impairment and just needed help with personal care and assistance with daily activities. But for the first 3 years of her stay in that facility, her conditions were well managed. By all accounts, all notices, she was a really pleasant lady. She was notorious for enjoying her food and her snacks. She had a little refrigerator in her room where she had ready access to all the things that she liked to eat. And she just sounded like somebody who always had a smile on her face when they walked in the room. Yeah, she really did. And she enjoyed her food and she enjoyed her snacks. Whenever she had the occasional acute complaint once in a blue moon that it was evaluated and managed to the satisfaction of the patient and her family. Her daughters were very involved in her care. And there's numerous notes over the years. In that kind of setting, there's at the very least like an annual meeting and the families are involved and, it's a multidisciplinary dietary and all that kind of stuff. It just sounded like for the vast majority of her time there, she was very happy. And I can't share them with you, but of course, as I was going through the chart, I saw some pictures and in all of her pictures, like she's got a big smile on her face and stuff. Yeah, actually, I wish I was that happy. Like she just seemed like somebody who was a perpetually happy lady. And yes, living in an assisted living facility as a long-term resident and then progressed to the more, more supervision, but it just seemed like she had her food, she had her snacks, she had close interactions with her family and was a favorite of the staff. And whenever anything went wrong, that it was managed appropriately. So that's how we start that, thankfully, for the first years of her life there. Yeah. But I was I was looking at this thinking, wow, it's really nice to hear because, of course, you always hear the horror stories about any kind of facility, but you don't hear that there are facilities where the staff are really helpful and positive and they care and they take good care of people and the patients are happy and all that kind of stuff. So it was really nice to read that story. So that's the way things went for the first 3 years for the majority of the patient's life there. So the items of interest or the circumstances of interest began on it began on a Wednesday. And so what happened was that the RN who was supervising the shift at about 6 o'clock in the evening or so was notified by the nursing assistant that this patient was complaining of severe right hand pain. That's what came to the RN's attention. So the RN went to examine the patient and noted that, and it was a good note too. Like this, it just seemed like a really solid facility. The RN documented that the extremity was cool to touch as compared to the left side. The capillary refill was sluggish. There were palpable radial pulses. The digits were stiff and tender, and that he noted an ecchymosis toward the base of the thumb that was between 3 and 4 centimeters. Just a really nicely detailed note for a facility where there's lots of people and comparatively few staff. So he makes all that note. He further documents that the pain started at about mid-wrist and extended to the fingers. The patient denied any sort of injury, doesn't know what happened, just started experiencing the pain. So the RN does this good assessment, writes a good note, and documents that the on-call NP was notified. And the NP then ordered a radiograph and said, I will be in to see the patient in the morning. So very typical, especially although it doesn't sound like she had a major neurocognitive deficit or major neurocognitive impairment. There's some neurocognitive impairment, and you just don't know if there is an injury that she didn't recall, or maybe something that didn't rise to to her attention as an injury. Anyway, for anyone listening who's thinking, geez, an X-ray, do you want to give radiation to somebody under that circumstance? But in that circumstance, that's a very fair assessment. In addition to the fact that there may or may not have been an unidentified injury, she was of advanced years and she did have arthritis and may have even had a pathologic fracture. Likely, it's not like the top differential, but it's very reasonable being off-site to order the X-ray at that point. So the next morning, the NP came in to evaluate the patient. And so here's what she records. And again, for listeners, just, listen to what she recorded and then think about maybe what she didn't or what she did and how that can impact things going down the line. So the NP, knowing that she was called the night before, knowing that this patient of several years duration in the facility, who's very pleasant and doesn't appear to be a complainer or have a lot of chronic acute problems, was having hand pain that was severe enough to the extent that she notified staff and they went and examined her and they appreciated the sluggish capillary refill, but the pulses were there, pain, a bruising at the base of the thumb, which can be many things. In fact, there's something, if anybody is interested in looking it up, Google thumb ecchymoses. There are so many different things, especially in the older adult. Yeah, that can present as like an ecchymosis at the base of the thumb.
Oh my gosh.
And the vast majority of them are very benign. There's a particular thing, a particular named name, like person's name, I think, name diagnosis. Of course, I can't think of it right now. But yeah, there's lots of things that can produce that
That's
finding.
so funny.
Yeah, so that's the first thing for your paper. Check out the thumb bruising.
I told you I need to.
So she documents, and the NP the next morning documents that the patient's noted to have ecchymosis at the base of the thumb, that it is tender to touch. There is otherwise no edema. The blood pressure is 156/80, and the remainder of the physical examination is unremarkable. So what's documented is the right hand pain and bruising is a chief complaint. The fact that the patient is in no acute distress. She's sitting up in her wheelchair. She is noted to have ecchymosis. It's tender to the touch. No swelling is noted. That's what's documented. Her vital signs were done, and her blood pressure was a little elevated at 156/80, but otherwise the remainder is just documented as unremarkable. The right hand radiograph that was ordered the night before is reported as no acute fracture, moderate osteoporosis, mild degenerative arthritis. The NP diagnosed, I'm sorry?
No, I'm saying, okay, I'm feeling my hand going, okay, as if I'm diagnosing my own.
Do you have any bruising at the base of your thumb? So she diagnoses right hand pain, negative fracture, continue pain medication, and follow. So that, when you, from a SOAP note perspective, the diagnosis and plan, or the assessment and plan, right hand pain, negative fracture, continue pain medication. So that's that. So that's that the next morning. The following day, the RN documents that she notes in her note, the right hand radiograph was negative. The patient is complaining about range of motion difficulty and pain to the right hand. Now, I believe this is Friday, right? It was Wednesday night when it started, Thursday when the NP saw the patient, and then the diagnosis of right hand pain, continued pain meds. The next day, the patient continues to complain of right hand pain and difficulty with range of motion. So in the afternoon, the nurse documents that circulation checks to the right hand are continued, and she notes positive cap refill. She notes that she reports to the NP. You know how it is. NP notified that the patient continues to have pain and trouble with range of motion, that the cap refill is present. Excuse me. And so a verbal order was given for a right upper extremity ultrasound to rule out a deep vein thrombosis. And again, some of you might be thinking, of deep vein thrombosis? Why are we looking for a deep vein thrombosis? How likely is a deep vein thrombosis in the upper extremity? Well, it's not especially likely, but it's really the next most likely imageable thing that you can investigate in this setting. Like at this stage of the game, and I'm Monday morning quarterbacking here a little bit, so I'm going to stop doing that. I'll wait till the end. But right now, ask yourself legit, what else would you do? What else would you do? Those of you that work in a rehab or long-term care, you probably have an idea. Those of you that don't might be thinking, well, geez, I don't know. So, just to put it all in context, here's this patient with no acute problems, and she's 79, and her hand hurts. And she tells the aide her hand hurts. So the nurse comes and looks at it and says, yep, there's some bruising at the thumb. Cap refill sluggish. Pulses are there. It's a little bit darker in color, I think, or it was cooler to the touch as compared to the right. Cool to the touch as compared to the right. And, that was on a Wednesday night. On Thursday, the MP comes in. The patient is still having pain. She's got this bruise. She's got some tenderness. The x-ray is negative. The next day, she's having some pain. It hurts to move her hand. There's good capillary refill documented. What else will you do? What else would you do? Well, everybody can ponder on that one. Maybe at the end of the conversation, we'll talk more about what else you can do. But we've already done an x-ray. And the only other really thing that is readily available in an outpatient facility like that, this isn't a hospital. They don't have an imaging department where you can wheel the patient down. So the deep vein thrombosis assessment, as you look at the potential diagnoses and the risks and the benefits and the availability of assessment, It's really the only other assessment, objective imaging assessment that was readily available. So she ordered it. The patient's daughter was notified by telephone because, like I said, the family was very involved in the care. The daughter was notified that the radiograph was negative and that her mom was still having pain. So they were going to order an ultrasound. And the daughter actually opined, and this was written in the note, that she thought her mom's hand hurt because she's like constantly holding her pencils too tight. And I guess she colors and stuff in her chair. Like I said, she's an active lady. So between the osteoporosis, the osteoarthritis, and perpetual, movement, the daughter was more of the mind that it might be due to that. So everybody is like, fine, okay, order the DVT. So the nurse at that point also documents that the right hand circulation check reveals edema, and that the right hand, I'm talking about right hand and using my left, which is bad. The right hand was darker and cool to touch. Circulation checks are being documented on a regular basis to the hand, and that was what was documented right there. The nurse also documented that she had placed a call to MD, which apparently was the nurse practitioner, and that the ultrasound had been ordered. The next note in the chart is Friday night. So this happened between like 1 and 2 in the afternoon. The next note is at night. The night nurse is there, and she does a circulation check and says the right hand circulation was examined. The hand was still dark and cool to the touch. The ultrasound that had been performed that evening was negative, that the MP was notified, and there were no new orders. Now, again, to put this in perspective, this is a Friday night, and I'm really not trying to steer anybody in one direction or the other. This is Friday night, not even evening. It's late Friday night. This is the night shift nurse. So she says she notified the MP. We learned later that the MP wasn't on call, that there was somebody else on call. So the NP that actually follows the patient all day and the one that had seen her the morning before had not been contacted about any of the last call she had was in the afternoon when she ordered the ultrasound. Okay. What else happened that day? When we went back to like, who got this call? What about this call that she said she made to the MP? Who got it if our NP didn't? And it turns out that there was an on-call service, like a contracted on-call coverage provider that took the call. And from their very limited record keeping, and most on-call places really don't keep a whole lot of detailed records, but from their perspective, they just documented that they got a call requesting clarification on a pain med, and that they clarified the med, and that was that.
Or anything like that.
Yeah. Nothing. All right. I mean, like a couple years later, of course, this on-call person had absolutely no recollection of that encounter at all. All we had were her records to go by, and she briefly documented that she had been called to clarify, like it was like a 1 to 2 tabs kind of thing. Yeah. And the nurse that was on call wanted clarity there. So that was that. So next we have the weekend. We have the Saturday. On Saturday, there are orders to give hydrocodone, acetaminophen, Norco or something like that, TID for moderate pain. Where those orders came from is nebulous and ill-defined. We don't know where those orders came from.
Really?
Orders were entered, yeah, but they weren't. So assuming it was from the night before that call, but interestingly, there's no paper trail to that, so who knows? So the pain orders were entered. There was only one circulation check that day. It was recorded at night, again, like late evening when the 11P to 7A person came in. The 11P, I think it was an LPN, documents that the right hand is dusky, cold, and painful, that MD is aware, no new orders, left a message for the full-time NP, our NP, to evaluate. So again, the nurse documented this on Saturday night. The MP is off until Monday morning, so she wasn't who was notified. Presumably the on-call service, like we don't know. Just the note says NPX was notified, but we know she wasn't because she wasn't there and she wasn't taking call. So that was Saturday night. Sunday, there is actually no documentation of the assessment of this patient at all. There's nothing in the note. which again, this is not, it's not an inpatient facility. It's not a hospital. In a hospital, we'd be like, doing circulation checks frequently and all that kind of stuff. But this isn't that. And so if the shift coming in was not, and we don't know what happened, but if the shift coming in wasn't advised that there was any problem at all, well, they wouldn't go in there proactively. So there's just no documentation. So we have no idea what happened on Sunday or what didn't happen. What we do know is that the next documentation about this patient was on Monday, and a nursing note Monday morning documents that the hand is dark, cool to the touch, and that the NP will be in to evaluate the patient. Our NP comes in to see the patient, and the patient is immediately sent to the emergency department. Oh, no. The NP on this day notes in her progress note that this is a right hand follow-up. The history of present illness summarizes events that she knows of since she was first contacted on Wednesday night. On this date, on this morning, Monday morning, she finds the patient to be in acute pain, holding her own hand, holding her right hand. The physical examination was documented as very limited because the patient said it was just too painful and she wouldn't allow a proper assessment. The note did document that the hand was dark, that capillary refill was there, or rather that the hand was dark, but that cap refill, strength of pulses could not be checked. She diagnoses right hand pain, reports color change and concern for vascular occlusion. So the patient was sent to the emergency department. The nursing supervisor was notified. The family unit was notified. The patient goes to the ER where she is diagnosed with an acute arterial occlusion. And the family at this point opted for conservative management. Like the answer was revascularization or an embolectomy or some invasive arterial surgery. And at this point, the family opted not to do that. They wanted conservative management. So the patient was transferred back to the facility where she lived for another year. And then she died. And so so she died at the age of, I guess, 80 at that point, 80 years old. She died almost a year later after the events of this Wednesday till Monday occurred. And so the NP is being sued. So there was the assertions against her were that she failed to perform an appropriate circulation assessment on the first visit on Thursday morning because she did not document pulses, cap refill, color, or temperature of skin. So that was the first thing. And let's revisit that in a minute. The next thing that was asserted of her is that it is very likely, the expert goes on to say, it's very likely that given the findings documented on the 27th and the findings documented by nursing on the 29th, had the NP done a proper circulatory assessment on the 28th, it would have revealed signs of circulatory compromise, requiring prompt transfer, and so the patient would have had intervention, 3 or 4 days earlier. And so that was a criticism that she didn't do that. There was also a critique of her offering the venous ultrasound. What the expert said was that she shouldn't have ordered the ultrasound because that wasn't appropriate in response to the nursing staff reporting continued right hand pain, dark in color and cool to touch. They didn't suggest what she should have ordered, just that she should not have ordered the ultrasound.
Oh, that's wildly convenient.
Yeah. Yeah, it's just the same old, it's just like the old school, don't tell me what's wrong.
Right.
Tell me what needs to be right. You know, it's certainly easy to sit there and call. But so I wish I could share with you. I have the picture of this lady's hand. Acute arterial occlusion. Now, the picture I saw was many months later, but it is like from about halfway through the dorsum. You could take a Sharpie and draw the line. And from here up, and the thumb up, it is completely black. Black.
Oh my
God. Completely black. Not, red or dark or dusky, not faded. It's like a black glove. It's a black glove that starts right here.
Like frostbite? Like that kind of look where it's just like Death.
It's just dead. It's just an absolute,
Oh my
it
God.
is like somebody took a black glove and like cut it short and put it on. So it just covered her fingers and to the mid, the mid, what's that thing called? A hand, halfway down the hand. And then the rest of the hand looked fine. The rest of the hand looked fine.
You just sprung on everybody that, so a year later she died. But how did she died as a result of complications of the hand?
Had nothing to do with her hand.
Well, all right, this is going to sound really jerky, but why are we talking about this? Why is she sued?
Because it's just because, unfortunately, it's the world we live in, the circumstances we live in, and if just somebody whispers the word lawyer.
But there was an option.
I don't want to sound like I'm lawyer hating here. I'm really not. But that's what happens is that, people will say, oh, it's like there's a whole psychology thing of, and I'm not getting all psyche on you because I'm a psych MP, but there's this whole thing that when something bad happens, we want to find a reason. We want to have something to blame it on. We want to have something extrinsic to believe it on, to blame it on. And that's just human nature. We don't want to just say, well, it's just that time. So there's that. And then when the family has that and they're struggling, and like I said, by all accounts, this was a happy lady. So I'm sure they really missed her. I'm sure that her death was a loss to the family and stuff like that. And so, you're looking for something to blame it on. And then all it takes is for somebody else to say, well, I'll bet this is all like ever since her hand, she hasn't been well. Ever since that happened to her hand. Now, like eventually, like for a period of time there, it did hurt her. She was in pain. Sure. Dying tissue hurts. Sure. Dead tissue doesn't. Dead tissue doesn't hurt. This is the cardinal rule of debridement. When you're debriding dead tissue, you don't need to anesthetize anybody. You just start cutting stuff away because dead tissue doesn't hurt. So once the family opted to let the hand die, and I'm not being critical of that either. Somebody with arterial disease, we don't know what the underlying arterial disease was, but doing revascularization or doing arterial surgery, it could have been extremely difficult for her to heal. I mean, it could have made things worse. So a conservative approach wasn't an unreasonable one at all, but it was their choice to not intervene and allow the hand to die. And they were advised of how that goes and the potential consequences. Honestly, I'm stunned that she spent like a year with that much dead tissue and didn't get septic.
Me too. Me too.
But she didn't. In fact, the picture I have of her with her hand, she's like, again, sitting there with a big smile on her face, in her chair and stuff. So, yeah.
So I have a silly question. Do those things, does that get amputated like partially or quite honestly, she would just had these kind of dead fingers?
No, in a different circumstance, like the definitive intervention would have been to amputate.
Yeah.
Like the definitive intervention would have been try to either like lyse the clot or revascularize, like depending on exactly where the artery was. I don't know all the specifics of the revascularization, but in the immediate phase, just take age and chronicities out of the picture. In the immediate phase, the conversation would have been about the risks and benefits of lysing the clot or removing the clot or revascularizing the hand. But then once they opt not to do that, the tissue is going to die. And once the tissue dies, then it's either do you amputate and have the associated risks and consequences of amputation, or do you leave it there and take the chance on sepsis?
Jeez.
And so, I've seen, there was a time, I haven't done it much for a long time, but there was a time where a significant part of my practice was rounding in long-term care facilities. And it definitely was, that was always the question, like if a digit went necrotic or something, or the toes went necrotic, the question was always risks and benefits of amputation, and the risks are poor healing.
Yeah, and sepsis, that's the other thing. That's funny. That's the first thing I think of, that you wouldn't want to do that. But honestly, I didn't even think of the other side. Like, how is she going to heal? Like, if there's, to your point, underlying issues, what if she had more clots? And then now you're back in like the same exact scenario. Something else dies,
Exactly. You just don't know. Like, she may not have had that bad of an underlying arterial disease. and she might have healed beautifully, or she might have had significant arterial disease and it wouldn't have healed. Just side lateral note here. When I was first an MP, my very first job was in an acute care. I was an acute care MP before we had that name. But that was my job. I went to work, picked up my beeper, made rounds on the inpatients all day, saw my patients, decisioned, whatever. That was it. And my service had all of the admissions from the 14 long-term care facilities in the system. It was a big healthcare system, and they had these 14 long-term care facilities in the city. And whenever one of the residents typically would have a change of mental status or any acute thing, they would send them to our hospital and my service. So I managed a lot of people from long-term care when they were admitted in the hospital. And in the very beginning, when I was still learning my way and didn't know my job very well, I did notice very quickly that if somebody came in with like a gangrenous fifth digit, in the toe, like a gangrenous little toe, I would consult surgery. The surgery would take them off to the OR and come back with an above the knee amputation. And I was like,
what?
And it happened. So now this was, God help me, over 30 years ago now. Like and these were patients where there just wasn't a lot of resources for really aggressive care. This was end game, like this was palliative stuff. And so I would consult surgery, the same surgical team, these two surgeons that worked together, they trolled the halls, always joined at the hip. But I would refer a patient with a necrotic toe and they'd come back with an above the knee amputation. And finally I said, guys, what are you doing? What are you doing with all these legs? Where are they all going? And why does it have to be above the knee? And they were like, Sally, which, you're going to feel stupid when somebody says Sally. The answer is that the problem that led to the necrotic toe was vascular disease that extended so much further up. He said, if we just cut off the toe, it wouldn't heal. And then we'd have to take off half of the foot, and then that wouldn't heal. And then we would have to do it at the ankle, and that wouldn't heal. And it would be below. And you would see surgeons do that too. Or families wouldn't consent, and it's just like progressively chopping off the leg. If in that circumstance, taking off the leg above the knee afforded the best opportunity for real wound healing. Even if they would never be able to ambulate, it was the best way for healing, because up there, the femoral artery is like the size of a turnpike and usually not affected by the things that get the smaller one. So anyway, I digress a bit, but those are the issues here. So I totally get why the family, and I'm sure the patient was part of the conversation too, that, this was, like I said, this was a solid facility. There were lots of meetings and stuff, and that everybody knew what the risks and benefits were, and this is what they opted to do. So then, a year later, when the patient dies, it's like the end. This is what happens. Everybody looks at these charts with a fine-tooth comb, and is there any way? And you can almost always make an argument for one side or the other. But in this particular case, the assertion was that she failed to appropriately diagnose and evaluate the hand after that first visit. And then there were assertions that she didn't respond to contacts by staff over the weekend. She didn't order aggressive enough monitoring. I mean, all the things. What else could you say? I mean, of course, that's what they're going to say. But when you take this, when you take it at face value, when you look at it proactively, which is what the MP has to do, she's got this patient who's, basically she's a stable patient. She has chronicity. She's an older lady. She's got some impairment. She is wheelchair bound and she has to live with assistance on a day-to-day basis. But she's stable. She's happy. She's interactive. She likes to eat, all the things you want in that circumstance. Yeah. And then her hand starts to hurt. So you get a call about her hand hurting. And the first call is like, well, she says it hurts. It's cool to the touch. Cool isn't cold. Right. Arterial occlusion makes really, really cold hands. That wasn't what the description, that just wasn't what it sounded like. There was always a documentation of a pulse. There was always documentation of a capillary refill. One person said it was sluggish. Somebody else said it wasn't. But the nurse practitioner gets a call that night. She comes in the next day, she sees the patient, she evaluates the patient. I think we'd all agree that it doesn't sound emergent. It sounds like it hurts, but it didn't sound emergent. Her vital signs were stable. The NP documents that there's no acute distress. One of the criticisms, and this is for just all of us to think about as we keep harping on documentation, one of the criticisms was that she didn't document a detailed vascular exam, and she didn't. document a detailed vascular exam. She documented that there was a bruise. She documented that it was cool, but she documented the way a lot of us do, charting by exception. So
Right.
you note what's wrong or atypical, and then the remainder of the exam is within normal limits. And in her deposition, she said the remainder of the exam was normal. The pulse was good. Cap refill was good. If I didn't document something, that's because it was normal. And that's a very typical standard of care kind of way to approach it.
How we all chart, I feel like.
How we all chart. However, just learning point, a little teaching moment there. In retrospect, if you're seeing a very specific complaint, the pertinent negatives are just as helpful to document as the pertinent positives. And so even though I would never say it was a deviation from standard of care, because charting by exception is what we all do, but going forward, I can tell you that I always do now, not just because of this case, but because I've seen it so often. If there's a specific complaint like this, like the hand, even if the pulse was there and the color was good and the cap refill was good, we're really best served to chart those things, just because then in retrospect, there is absolutely no doubt about the fact that it was done. So it's a line here. It's not a deviation from standard of care not to do it. But boy, would it have helped. Just would have helped in general to be able to go back and see it. So think about the time it takes to check those things off in your note. And there's that. So anyway, that's the only time she saw her. The x-ray was negative. The hand hurt. It was not acute. There were no concerning findings. And the MP goes on about her day. She gets I guess she gets a call later on about continued pain. So she orders the ultrasound, which is the next thing that is readily accessible to her. And that's the last she hears of anything.
Right.
That's
she wasn't
the
on
last
call,
she
right?
hears. Right. She wasn't on call. The next thing she knows, she comes in on Monday morning, the patient is acute, and she sends her to the ER. So
Wow.
where is where? Go ahead.
About the ultrasound, doesn't that check? I mean, I know it's a venous ultrasound, because, and to your point, they didn't even offer this would have been better, but am I being goofy? A venous ultrasound only checks veins. We're not looking at arterial blood flow at all. Yeah,
you don't. It's different. They're different assessments. If you want to look at the artery, if you want to see the artery, you could order an arterial ultrasound. You
Dang.
could. And it's different. It's different. The way that study is performed is different.
Was that part of that, the case that you didn't check the right vessel?
Actually, nobody commented on that. Nobody commented on that, oddly enough. But and somebody could have asked the question, but in the scheme of things, arterial clotting is so much less common than venous clotting.
Yeah.
In your list of likely, in the upper extremity, both of them are really uncommon, but arterial, much more so. And again, the fact that the pulse is, anytime anybody checked a pulse, it was there.
Yeah.
The skin, the documentation is that the color is darker, but what does that mean?
Right.
We can look back now that we all know it was an arterial problem, we can look back and say, oh, that was artery. But in the moment, there were two options for this MP. Either do the thing she did or send her to the emergency room.
Yeah.
And of course, what they say about hindsight being 20. Everybody say, well, she should have sent her to the ER. She should have sent her to the ER. Did I mention this was 2020? This was May of 2020.
Oh,
remember what happened in May of 2020?
Yes.
On March 13th of 2020, the world stopped, right?
Yes, we do.
The world just shut down. And by May of 2020, when we were in totally high gear, remember, all the resources were being mobilized. Hospitals were being set up in convention centers. And it was just, that was the peak of the madness. And you didn't send somebody to the emergency room then unless they had COVID.
Yeah,
really.
Absolutely.
You were encouraged not even to send them for an MI. You didn't send them to the ER unless it was really, really an emergency. Not only because there were just no resources, but then a lady like this is more likely to get COVID there than anywhere else.
Right, exactly. And then now you're in big trouble, right? And I'm trying to be not know the case, right? Not Monday morning quarterback, but it never sounded like this was a life-threatening emergency early on, that like sending to the ER may have even been perceived as like, what are you doing?
Yeah.
Like you're wasting resources. Stop doing that.
Absolutely. Absolutely. If she had gone to the ER, she probably would have got COVID there and died sooner than she did.
Yeah.
I mean, we can all probably. Now we now this is all about opining, but really in May, I mean, I don't know that I would have sent her to the ER at any time. I don't know, based on the things I was reading. Now, had this gone on for like several days, even if it wasn't acute, but remember, the MP gets a call at night. She sees the patient the next morning, not looking emergent. She orders an ultrasound for that night. The ultrasound is negative. That's the last she hears of it.
Yeah.
So at any point in that discussion, would any of us have sent her to the ER? It always cracks me up when I hear people say, "Oh, I would have," or "I would have known," or "She should have known." It is always really easy to be brilliant when it's not your patient and you're not in the moment. But
exactly.
I wouldn't have sent her at that point. I wouldn't have sent her even if it wasn't COVID, just based on but I would have followed it. I would have totally followed it. And if it continued to deteriorate, okay, now we have a negative X-ray, we have a negative ultrasound, and it still really hurts her. So yes, then I probably would have sent her, but not in this circumstance. So what the MB had on board, then throw in May of 2020.
Yeah,
there's no way.
That.
They wouldn't have taken her. The ER wouldn't have seen her.
I'm so interested. How did this play out for the NP in this case, considering too, it was a year later. I'm assuming when she died, it was unrelated. I'm just making that assumption.
Yeah, but I was like, cardiac arrest secondary to her various chronicities and stuff. The MP was dismissed.
Okay. Wow.
The MP was dismissed from the case, but I don't know if anybody. I mean, there's always everybody that they're taking a look at here. So was it that the staff didn't communicate well? Did the on-call person, did they not do what they should have done? Like there's others, there's of course other people that were being evaluated. Even the NP's collaborating physician who had nothing to do with nothing. When I was reading his deposition, at one point he said something like, he's like just offered the opinion that maybe they could have communicated better. And I thought, who asked you? Be quiet. You weren't there. This is also 101. You don't start offering opinions that are counter to the position. I'm not saying if there was actually something contributory that you don't share it, but that's just an opinion. Well, maybe we could have done this better. Well,
yeah.
Thanks. Thanks for no thanks.
Right. Pipe down, sir.
But I mean, that is, that is a classic. Oh, in retrospect,
of course,
we could have done this or this, but that's not the way we look at these. It's prospective. It's contemporaneous. What were the circumstances and what was available and what did the MP know at that time?
We all play that game, man. Only if we were so good at being able to forecast into the future and not make mistakes, right? That would be great.
I'd have a lot less divorces under my belt.
Oh my gosh. Well, thanks for sharing this, Dr. Miller. This was an interesting story. I didn't see this a year later. I'm like, what happened? This is a turnout that I didn't expect. I appreciate you sharing that.
Isn't it just crazy though how like anything, like everything we do, in a couple of years we can be getting served with complaints going, what are you talking about? What?
Yes.
But we can.
And it's true. I mean, honestly, I think it is a testament to the importance, the gravity of the work that we all do as healthcare providers, as practitioners like yourself, who are really doing all the care for patients. I mean, listen, this is not like an easy job. It is in no way, shape, or form is it. And I think at dealing with people at all, caring for people at all in any way, there's that factor. But here you go, dealing with health and life and death. It's a mega job. It is a mega job. Wow. Yeah. Well, thanks for that. And we hope you guys enjoyed the story listening into this. And if you want to hear more, check us out on FHA.com. We got lots of different episodes for you to enjoy and to learn from, right? And help us to maybe forecast a little bit better, right? Looking into what we're doing and how we're doing it and why we're doing it. And everything helps, right? Everything helps. So we take it for that.
Everything does.
Yeah. Well, thanks for joining us, everyone. And until next time, goodbye for now.
Thank you for listening and learning with Scrubs and Subpoenas, Tales from the Witness Stand, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com. Join us again next time as we dissect more medical malpractice cases.